All right, let's get started. Welcome to our first concurrent session for the National Brain Injury Australia Conference. My name is Professor Leanne Torr. I'm a professor here from the University of Sydney, and I'm delighted to be able to welcome you all here to our beautiful campus and to the Sydney Business School. I'd also like to begin today by acknowledging the traditional custodians of the land that we're on. It's the Gadigal people of the Eora Nation that we're on here today, and we think that they were here for over 60,000 years, telling stories and sharing and teaching and learning with each other, and so it's a real privilege to be able to do that here on these lands. I'd like to pay my respects to their elders past and present and emerging. So thank you all for coming today. As you would know, today's session is about the Aboriginal and Torres Strait Islander experience, and we have three excellent speakers, two of whom are on Zoom. So our first speaker is on Zoom today. Our second is in person, I'm hoping, somewhere here. Yes, there we are. Hello. Welcome. And then our third presentation is on Zoom. So if we have time, we'll take questions. It'll just depend on how people go with their presentations. They should all be about 20 minutes long, hopefully. Yes. So our first speaker today is Dr. Michelle McIntyre, and she is going to speak to us about the Good Eye Way, or Gut Eye Way screen, developing a culturally sensitive cognitive screen for Aboriginal and Torres Strait Islander peoples. And I'd like to welcome Dr. McIntyre. There she is.
Here I am. Lovely. Thanks so much for that introduction. Yeah, I'm Dr. Michelle McIntyre from Synapse Australia. We're a peak body for brain injury based up in Brisbane, and we operate nationally. So, yeah, I'm speaking today about, it's the Gut Eye Way screen, and we've developed this screen to flag for cognitive impairments and psychosocial disability in Aboriginal and Torres Strait Islander adults. I'd also firstly like to respectfully acknowledge the traditional owners of the lands that I'm on today. Up here in Brisbane is the Jagera and Turrbal peoples. I pay my respects to elders, knowledge holders and leaders past, present and emerging. I'd also like to really acknowledge the elders and cultural advisors and all the other respected community members who worked with us on this project and guided the Gut Eye project. We've been doing this work for quite a few years now. And they also gave me permission to report on this work today. So the Gut Eye work originated up in far north Queensland about 4 years ago. And the word Gut Eye actually means come home, come heal, come rest. That's the traditional language of the Kuku-Yalanji peoples up in that area. And we were actually given permission from a traditional owner to use the word Gut Eye. So the work we were doing up there, some of the Indigenous services that we were working with really wanted a better understanding about possible brain injury, cognitive impairments that their clients might have. And that's where the work started, really. So that photo there on the left shows a smoking ceremony that was done as a way of blessing the project when it first started. And all the way along, the development has continued in close partnership with Aboriginal and Torres Strait Islander stakeholders. So it's definitely a screen. It's not designed to be diagnostic. I'm sure many of you are aware diagnosing a cognitive problem or a brain injury takes a full neuropsychological assessment carried out by a health professional. So, you know, they can be expensive, take a lot of time. They're not always available outside of urban settings. So a screen can be really useful in these cases to just better understand what might be going on for people, and then to guide referral support strategies and further testing. So in that sense, the Gut Eye screen can be administered by non-clinicians with training. And The photo there on the right shows two of my colleagues, Auntie Colleen McLennan and Uncle Adrian Padmore, and they're both trained Gutty administrators. So the assessor training covers things like it's the technical aspects of administering the screen, as well as the issues related to informed consent, ethical use, risk management, and cultural safety. So just to give a bit of background, risk factors for cognitive impairment can be high in some Aboriginal and Torres Strait Islander communities. Risks like violence, alcohol and substance problems, stroke, brain injury, poor health and nutrition can all result in cognitive impairment. And I really want to stress here that this isn't the case for most Indigenous people in Australia. Indigenous peoples and cultures are resilient, flourishing despite ongoing racism and discrimination since colonisation. But of course, the impacts of intergenerational trauma, things like forced removals, disadvantage, has marginalised some Indigenous communities. So for those people, the risks of cognitive impairment is actually high. But despite these risks, there's a lack of culturally appropriate ways to assess cognitive function. It's well documented that standard cognitive tests can be typically based on Western concepts. They emphasise literacy, numeracy skills, and this can disadvantage people. So results of screens and tests won't be reliable if the methods are not culturally valid, and also, crucially, if it's not culturally safe. So the engagement and administration processes are often experienced as unsafe for people who often have had really negative experiences with mainstream services and health assessments. And of course, if cognitive problems are misunderstood, misdiagnosed or not identified, this can really have enormous health and social consequences for people. People can end up in homelessness situations, engagement with the criminal justice system without their issues and capacities being understood, and just not getting appropriate support. So the Gutty was developed with these issues in mind. And feedback we got from cultural stakeholders was they really stressed that the process needed to be a holistic process. So it wasn't good enough to just sort of go in and do a cognitive screen in isolation. It needed to capture the complete story of the person to be culturally appropriate. So for that reason, there's multiple components to the Gutty interview. We use an acute screen, and that assesses any immediate physical needs or mental health problems that the person might be having on that day, and their capacity to undertake the screen in that moment. Have they had medication? Has something terrible happened, that the day before that they need to address? Is there medication they need to take? Are they in pain? So all of those things are done before we launch into any further assessment. Then there's the cognitive screen, which is there's 12 items. I'll talk a bit more about that later, but 12 items are related to multiple cognitive domains that are relevant to brain injury and neurocognitive disorders. We also include depression and trauma screens and a needs assessment. So the needs assessment we developed with Dr. India Bohanna. We're still doing some work around that. And basically it looks at any areas where people might need additional support. So we ask, across these domains that you can see up on the screen, do people need support with it? Do they currently get support? Would they like support? Is how that's framed. So broadly, the overall purpose of the Gutty Way screen is to understand where there might be possible cognitive impairments and the associated functional impairments that might go with those, as well as mental health symptoms and unmet support needs a person might have. And this is all then used to guide further testing and referral. And support strategies are given based on what where the person may have flagged on the gutty, so that the service supporting them has concrete ways to actually support the person, and then recommendations about further testing or referral are also made. So the development process involved equal consideration of clinical and cultural factors. So we worked with a clinical neuropsychologist to develop the cognitive screen. We looked a lot at the literature and existing culturally developed tools like the Kimberley Indigenous Cognitive Assessment, the KICA. We identified items that related to cognitive impairment and were seen as culturally appropriate from the perspective of our Aboriginal and Torres Strait Islander stakeholders. So we did multiple feedback and focus group processes with both the clinical and the cultural expert panels. And our cultural stakeholders also guided the protocols that are in place around the engagement and the administration of the screen. So that cultural protocol really underpins the screen, and it guides community engagement, and as well as the culturally safe methods for administering. And this photo here was one of our cultural development workshops with some of the arties and some other people who were working with this as we developed the screen. So after we did a small pilot in an Indigenous sentencing court, the elders group there talked with us about changes that they thought were important, and we did a series of focus groups then as we reviewed and refined and to get to the final version that we've got now. And what's consistently been stressed by community advisors was this issue of people feeling safe. And there are many strategies that were recommended that we include. Firstly, that ideally it should be administered by an Aboriginal or a Torres Strait Islander person as appropriate, and also include a trusted support person so that the person doing the gutty is with someone who they know potentially through a support service. And then if the person administering is non-Indigenous, then they must have a high level of cultural competence, as you know, and be vouched for by the service that are providing, that are doing the gutty. It's delivered in a yarning method, so it's more of a conversation than a clinical structure. So there's 2 and 4th sharing and getting to know each other in this conversation. It's not just that clinical, someone sitting down asking questions and ticking boxes. Guided by trauma-informed practice models in terms of how the tools are introduced and what supports and processes are used. Genuinely informed consent was highlighted as really important. So it's not enough to just sign a consent form. It's important that people understand potential risks of doing the screen. You know, what might that mean for them if they flag? What does it mean if they flag? We don't want people to be concerned. So it's really important that there's that people understand any risks and benefits of doing the screen and understand what it means when they get the results, so that it's not concerning for them. Another really important aspect in relation to consent is the stipulation that elders of the area have invited the use of the screen and agreed to its appropriateness in that particular context. So in that way, there has to be a lot of flexibility. So, you know, there's waiting to be asked, I guess, and then connecting with community in that area. And you know, if people are then interested in using the screen, then in new places, we'd go through a process around that. And so another aspect of safety therefore is building capacity in services who support people so that they learn about brain injury and cognitive impairment. They understand what the gutty is and how it works, so they can inform their clients about what's going on. That's really important. So there needs to be a demonstrable benefit for the individual that can be explained to people in terms of what outcomes they can expect and why it's a benefit for them. It's not something that people just get sort of railroaded into doing and don't know, can't see, don't know why and don't know what will happen. So these are the cognitive domains for the cognitive screen. So we focused on those 7 broad domains, excuse me, that you can see there. And these are all associated with brain disorders, orientation, language and verbal communication, memory, praxis, visuospatial skills, executive function, and attention and concentration. So a lot of the tasks, so there's 12 tasks, and some tasks relate to multiple domains as well, not just one. So the tasks are on the right-hand side there. So a lot of the tasks, especially the later ones, there was an emphasis on executive skills, particular regulation, abstraction, and flexibility. So we don't score the screen as a whole. People get a score or a flag on each task, and any problem or any error, there's some scoring within the task, but it's not all added up. There's not sort of cut-offs, but it just flags, therefore, that a person might have a problem, in executive function. And so if someone flags in that domain, for example, that then sort of triggers a statement around what types of problems that person might be experiencing in terms of functional impacts around communication, social interaction, self-management, self-care, and learning. So any flag is reported as a possible area of concern, and the language is around it. This person possibly has a problem in this area. If they do, or if you say it's memory, there's possibly a problem with memory. If they do have this problem, here are some things that they might be experiencing. Here are some strategies you can use to support them. Excuse me. So we've done, I think we've done a few more now, but at this point, 78 full screens, primarily in Brisbane and Cairns. And within that group, it's been a wide range of areas and backgrounds that people had. So in the acute screen, we ask about history of head injury. So there's a self-report history of head injury in the acute screen, and that was quite high. 77% of that 78 people reported a history of at least one head injury. And of those, 93% had reported loss of consciousness with that. For a lot of people, they reported multiple head injuries. So 22% had 2 or 3, and nearly 14% said they had lost count, that there was, multiple times. There was a relationship between self-reported head injury and the people who flagged on the cognitive screen. So 85% of people who flagged on the screen also reported a head injury. Now, of course, there can be people who had head injuries without any associated cognitive problems, and conversely as well, cognitive problems and no report of head injury. They could be through other causes. And sometimes people don't want to disclose as well. So, but we're currently doing some detailed analyses on all of that pooled data. So these are the results for the cognitive screen. So 52 people, 67% overall flagged, so got some errors. Problems were seen most frequently in executive skills, primarily regulation. So those types of problems can manifest as problems with impulsivity, self-monitoring, planning, prioritising, and people could benefit from support with things like social interaction, making decisions and planning, following instructions. And the other, attention and concentration was also quite high. So in terms of validation, we have got some publications ready to submit. I've been working on a development paper which outlines all the processes we went through with development and the processes we used to test face validity, content validity and cultural validity. And that included all those project team working panels and focus groups, clinical and cultural expert review processes. And we also undertook a small predictive validity study in far north Queensland to look at the predictive value of the screen to identify the presence of cognitive impairment. So what we did was compare the results of the Gutty-Way screen to the outcome of a clinical interview with a psychologist. So those results were really, really good. They showed that Gutty has a predictive value of 0.91. So 91% of the people who tested positive or flagged on the Gutty, when they were assessed by the clinician who didn't know how they'd gone on the Gutty, there was 91% agreement that from the clinician of the person having a cognitive impairment. And all of those details are being reported. So my colleague Kylie Rixon's writing up that validation data from the North Queensland study and also all the pool data. So to conclude then, the Gutty-Way screen shows promise as the culturally validated engagement and screening process to identify cognitive impairment and psychosocial disability in Aboriginal and Torres Strait Islander adults over the age of 16. Thanks so much for listening, everyone. And I believe we'll have questions at the end, so I'll hang around.
Thanks, Michelle. Yeah, we need to keep moving because we'll be out of time. So thank you very much for your presentation. We're going to move on to our next speaker now. You okay?
Ready to go. Is that right? You can get that up. And pointer. And
You're all okay? I think you'll probably have this microphone. Yes? So just while we get Anthea set up, Anthea's our second speaker. She's going to speak to us today about responding to acquired brain injury in remote Indigenous communities, getting the foundations right, and Dr. Anthea Krieg is going to present that for us. We'll just wait for her to get her microphone set up.
this goes. Hopefully that's them. Right, and I'll take this.
Okay.
Oops.
You all set?
Oh, I think so. Hey everybody, and thanks Michelle for your presentation. It's always good to hear the great work that Synapse is doing. So my name's Anthea. I we'll be talking to you about our experiences working with acquired brain injury, or attempting to work with acquired brain injury in some very remote communities. This picture is by one in a series of Ken sisters who live in Armada on the APY lands, and this one's by Sylvia Ken. So most of this work will be based on what we've been doing in the APY lands, but from my experience, and I think many other people, having worked in other remote communities, and the prisons is a remote community too in some ways, there's a lot of commonality across very remote areas. I've got quite a big acknowledgement to make. We meet on Gadigal country, and I want to pay my respects, as everyone else has, to the Gadigal people of the Eora Nation. I also want to particularly acknowledge the Anangal peoples, the custodians of the Anangal Pitjantjatjara Yankunytjatjara lands and the surrounding lands. Now, these people, the Anangal, are also the custodians of Uluru, and which I see as the beating heart of this country, and they've been the custodians for all generations since ancient times and all the way through to our shared future. We acknowledge Anangal people is the ongoing spirit, having their ongoing spiritual connection to this lands and all people's connection to Uluru country. And from the Uluru Statement of the Heart, we acknowledge our shared hope for all First Nations children to flourish, so they too will work in two worlds and their culture will be a gift to us all. That's only half of it. What I want to also acknowledge is the stuff I've been thinking about forever that gets me every time I do an acknowledgement to country, is how we don't talk about our white fella responsibility in supporting Indigenous people to thrive on country and to maintain the cultural connections to the future. We need to acknowledge how we have to cease our systemic injustices to Indigenous peoples, and particularly our ill-considered justice practices. And for remote communities, our major response to ABI at this stage, our major service response is incarceration. So these are the things we also have to acknowledge. We acknowledge our responsibility to challenge and repair our whitefella systems that are systematically disadvantaging Anangu people and all Indigenous people in Australia. And we acknowledge our commitment to an Indigenous voice to Parliament, to treaty and to a process of truth-telling so that we can work together to heal the harms of our shared past. So this is my first foundation, getting the foundations right. We acknowledge often in an acknowledgement of country of people's connection to culture and to community and to country, but then we do everything, we don't acknowledge all the ways that we white fellas block those connections. And we are actively doing it unknowingly in all sorts of ways, invisible ways. So for me, that's something of having worked with Aboriginal communities for so long and having thought so much it's about education, about people just needing to understand. It's an appreciation that our systems are just totally unable to work effectively with Aboriginal communities as they are. And each of us, and I'm sorry, I don't know, each of us as a non-Aboriginal person needs to really consider, if we have any engagement with Aboriginal people, how our business as usual is still perpetuating that significant level of disadvantage. So in this session, I want very quickly to talk a little bit about the APY lands and what the work we've been doing, and a bit about what that means for brain injury and how we are looking at brain injury in remote communities, and then a couple of other thoughts about some foundational issues there. The NDIS will get a mention, of course. This work was funded through an ILC grant, and obviously the NDIS now is the main focus for our responses. And it's led to a devolution, of course, of other state-level services, as most of us are aware as well. So that's one picture of APY country. Of course, Central Australia, and we think desert, but it's gorgeous country. We've got the Musgrave Ranges in the background, and quite often, and beautiful red earth, and then quite often it can be quite lush and beautiful flourishes of wildflowers and of growth. How do we get there? So this is my very favourite road sign in the country. It's at Port Augusta, so you drive up from Adelaide 300 k's, get to this sign and you think, do I want to go to Perth or do I want to go to Darwin? 2,000 kilometres of road one way or 2,000 the other way, and just big horizons. So to get to the APY lands, we choose Darwin.